For the heme-onc section, we're going to start with the approach of anemia in the ER. So MCV, or mean corpuscular volume, determines the size of the red blood cell. If the MCV is elevated, greater than 100, you get macrocytic anemias like B12, folate deficiency, alcoholic liver disease. Normocytic is going to range from 80 to 100 MCVs, and there's an extensive list. As you can see here, this is not all-encompassing, but it's a good start. Lastly, if it's less than 80 MCVs, you're going to start to see those microcytic anemias. Of note, that's the thalassemia, iron deficiency, lead poisoning, sideroblastic, and sometimes you're going to see anemia of chronic disease. RDW stands for red cell distribution width, referring to the variability of size of the red blood cell. So reticulocyte count refers to the red blood cell production. And so if you see a low count, I want you to think of underproduction from the bone marrow. And an elevated reticulocyte count could be due to overproduction due to peripheral destruction, like one of the above normocytic anemias, for example. Coombs test is used to detect antibodies directed against one's red blood cells. Usually seen, this test is done to diagnose autoimmune hemolytic anemia. Transfusions are a biggie on the shelf in terms of the shelf exam. 1 unit of packed red blood cells raises the hemoglobin by 1 to 1.5. O negative is the universal donor. AB positive is the universal recipient or receiver. During massive transfusion protocols, which vary from hospital, right? You want to be cognizant that a general rule of thumb for those massive transfusions is that patients that are losing red blood cells, they're also losing platelets and clotting factors. And so general rule of thumb is you want to keep a ratio of 1 to 1 to 1, meaning 1 fresh frozen plasma to 1 platelet to 1 packed red blood cell. Acute hemolytic transfusion reaction often arises secondary to lab error or incorrect type or matching. Patients are going to present with fever, chills, chest pain, hypotension. The treatment is to stop the transfusion right away and send blood to check for hemolysis. Febrile non-hemolytic transfusion reaction is the most common transfusion reaction. It occurs when antibodies from the recipient develop against the donor's white blood cells, and the treatment is you just want to treat that fever with antipyretics. Now, an allergic reaction is exactly what you're going to see: urticaria, pruritus, anaphylactic shock. TRALI stands for transfusion-associated acute lung injury. It's a form of non-cardiogenic pulmonary edema that often does not respond to diuresis. It presents with shortness of breath and hypoxia during transfusion reactions. Chest x-ray is going to show new bilateral infiltrates, and the treatment is supportive oxygen ventilatory support. And then autotransfusion is sometimes used in trauma patients undergoing orthopedic or cardiothoracic surgery to reduce the risk of infection. You also see it in patients with rare blood types and those who have hypotension associated with a hemothorax. The contraindications for autotransfusion are bacterial infection, malignancy, renal or hepatic insufficiency, coagulopathies, and then also if the blood is collecting in the autotransfuser for over 6 hours. And these patients will also need fresh frozen plasma and platelets as well. All right, so moving over to platelets and a couple more transfusion pearls. The indications for platelet transfusions is anyone with a platelet less than 10,000, anticoagulated patients with no bleeding but less than 50,000 platelets, surgery with active bleeding less than 50,000, a major surgery or invasive procedure such as a lumbar puncture, or thora, or paracentesis without bleeding with less than 50,000, or any ocular or neurosurgery without bleeding less than 100,000 platelets. If you have a trauma patient described in a question stem and you're trying to figure out the best laboratory test to discern whether or not they should receive transfusion, go with thromboelastogram. Thromboelastography measures the properties of whole blood clot formation under stress conditions. So it includes the interactions of platelets with various portions of the coagulation cascade. So it's much better of a test than doing the APTT and PT. It takes in account of the entire coagulation cascade. So trauma patient, you're not sure whether or not to transfuse, best test is thromboelastography. This is probably the most high yield table out of the entire video. So we'll start with disseminated intravascular coagulation, also known as DIC. It's a consumptive coagulopathy with concomitant thrombosis and hemorrhage. Thrombin, which is involved in clotting, if you remember, it's excessively produced and it leads to deposition of fibrin, leading to tissue ischemia and consumption of platelets, fibrinogen, and prothrombin, which leads to bleeding. DIC will have prolonged PT and APTT, thrombocytopenia, and then elevated FDP and low fibrinogen levels. The treatment is you just want to treat the underlying cause, whether it's sepsis, trauma, malignancy, or any sort of obstetrical complication. Hemolytic uremic syndrome, or HUS, is often presents with bloody diarrhea with either a foodborne illness. Often the origin is that E. coli 0157H7 or from some sort of contaminated water source. 5 to 10 days later, the patient may develop HUS. The triad of hemolytic anemia, thrombocytopenia, and AKI is the classic signs you'll see, and the treatment is supportive. TTP, or thrombotic thrombocytopenic purpura, there's 5 symptoms to be aware of, and they don't all have to happen. You don't need all 5. They can present at various times, but what you want to look out for is fever, anemia, which is microangiopathic hemolytic anemia, thrombocytopenia, renal failure, and neurological deficits, and those are typically transient. The mnemonic you've heard of is FAT-RN to describe the 5 symptoms, and the treatment for TTP is plasmapheresis. And then last but not least is immune thrombocytopenic purpura, or ITP. It's an isolated thrombocytopenia, so the remainder of your CBC when you get it back is going to be normal. Signs and symptoms include petechiae, purpura, bruising, epistaxis, chronic disease, which it's going to often affect women more so than men, and prednisone is your first-line treatment. And then there's some cutoffs for platelets. So if the platelets are less than 30,000, you need to treat. Platelets 30 to 50,000 with active bleeding, you need to treat. And then splenectomy is performed in refractory treatment or in the setting of recurrent episodes. So for ITP, steroids, IVIG, and then if it's refractory to treatment, you go ahead and do splenectomy. Lovenox, or low molecular weight heparin's reversal agent, is protamine sulfate, and it's 1 milligram per 1 milligram. It's a 1-to-1 milligram ratio. Heparin, on the other hand, inhibits clotting factors, so you want to monitor the APTT level. And protamine sulfate is the reversal agent for heparin as well, but it's 1 milligram reverses 100 units of heparin. Heparin-induced thrombocytopenia occurs within 10 days of heparin, sometimes Lovenox use as well. Platelet will drop with greater than a 50% decrease. Despite the dramatic drop, these patients usually don't have any bleeding problems, but because they have developed antibodies to heparin, they're at risk of clotting. You want to be wary of DVTs and PEs in these patients. Treatment is immediately stop the heparin, start anticoagulation with direct thrombin inhibitors such as bilvalirudin. Warfarin, on the other hand, inhibits production of clotting factors 2, 7, 9, and 10 in the liver and requires monitoring with PT-INR. And then in intracranial hemorrhage, in the setting of warfarin use, the reversible agent should be prothrombin complex concentrate, also known as K-Centra, and vitamin K. You can also use fresh frozen plasma, but it has a delayed onset, so it doesn't act as quickly as the thrombin complex concentrate, or K-Centra. What do you do if the INR is elevated? There's a few cutoffs that you need to look out for. So the table over here is a nice one that I made. Less than 5, there's no bleeding. You just hold 1 dose of warfarin, resume when the level's normal. 5 to 9, without bleeding, you hold 1 to 2 doses of warfarin. You want to consider oral vitamin K. Greater than 9, you hold warfarin and give oral vitamin K. And then if there's any bleeding, hold warfarin, give IV vitamin K. Consider fresh frozen plasma and K-Centra. Sickle cell anemia commonly presents with children, and they're going to have dactylitis, or swelling of their hands and feet, usually from the ages of 6 to 9 months. Vaso-occlusive crises occur when the sickled cells sludge up and obstruct various vessels, leading to ischemia, ischemic pain essentially, and it's precipitated by cold weather, infections, dehydration, high altitude. The leading cause of death is pneumonia and sepsis. Acute chest syndrome is an occlusive crisis that may present as a new infiltrate on chest x-ray with any one of the following symptoms: hypoxia, tachypnea, respiratory distress, chest pain, cough, and or wheezing. The only medication to prevent acute chest syndrome is hydroxyurea. The most common cause of osteomyelitis in sickle cell patients is salmonella. The second most common is Staph aureus. And these patients are also at risk for priapism or painful erection, which is treated with aspiration of blood from the corpus cavernosum. These patients are also at high risk for parvovirus B19, which causes aplastic crisis. The lab values you're going to see with aplastic crisis include anemia, a low reticulocyte count, and then splenic sequestration is when there's a quick drop in the hemoglobin as sickled cells become trapped, essentially. So the patients may develop hypovolemia, hypovolemic shock, and die. The treatment is transfusion and plasma exchange. And then very briefly, hemophilia A, that's due to factor VIII deficiency. And then if a patient with hemophilia has head trauma, regardless of the brain bleed, you should go ahead and treat them by giving them their deficient factor. Hemophilia B, on the other hand, is factor IX deficiency. And then von Willebrand disease, that's the missing von Willebrand factor, and the treatment is desmopressin. You can see here the mechanism of action. All right, moving over to oncology, hypercalcemia. It's the most common cause is hyperparathyroidism. Other causes include small cell lung cancer, breast cancer, and multiple myeloma. Symptoms include that classic stones, bones, groans, and psychiatric overtones. Get an EKG and you'll see that findings for hypercalcemia include a shortened QT interval. You want to start fluids and steroids in these patients. Virchow's triad is consistent of venous stasis, hypercoagulable state, and endothelial injury. In classic DVTs, you're going to get an ultrasound if you have a high suspicion, and you're going to treat with anticoagulation. I want to highlight two other kinds that you may see. The first is phlegmasia cerulea dolens, and this is when the iliofemoral venous system has an obstruction and it causes ischemia. It affects the superficial and deep vessels, so the collaterals are not perfusing appropriately. So the leg will appear cyanotic or purple, and these patients will have a lot of pain and a lot of edema or swelling. This is one of the few instances that TPA is an indication in the setting of DVT. And then phlegmasia alba dolens, that's going to be when the leg looks a milk leg, or it'll look white. There's total occlusion of the deep iliofemoral venous system, so the superficial veins, they're still open. The collaterals are open, so there's still perfusion. There's no cyanosis present, but there's still edema and pain. And so that's it. That's all for the Heme Onc video. Thank you all so much for your time, and I'll see you soon. All right, the last little bit here is just carcinoid and tumor lysis syndromes. Carcinoid syndrome is a serotonin secreting tumor, and the symptoms include flushing, secretory diarrhea, abdominal cramps. The best initial diagnosis workup is 24-hour urine for that 5-HT levels, and the treatment is octreotide. Tumor lysis syndrome, you're going to often see a variety of cancers, but the most often is the non-Hodgkin's and ALL. Or you'll see this also in patients who are undergoing chemotherapy, where large portions of uric acid, phosphate, and potassium are released into the bloodstream. The treatment is fluids, and in some instances with severe acidosis, the treatment includes alkalinization of the urine. Rasburicase is prophylaxis in patients that are at high risk for tumor lysis syndrome. And that's it. That concludes this Heme Onc section. If you have any questions, let me know in the comments, and thank you all so much for your time. See y'all later.